The benefits and the limitations of CPT can further be better understood by comparing it with other cognitive therapies. Various trauma treatments would agree that the common approach to treating PTSD is by changing the client's cognitive distortions and thereby helping them to better manage related symptoms. Because the effectiveness of continually processing of trauma-based exposure in cognitive therapy have been well documented in helping trauma survivors build tolerance in affective regulation, CPT will be compared along with other cognitive therapies such as cognitive behavioral therapy or CBT, which is forefather, prolonged exposure therapy or PE, which is CPT's close associate. And CPT will also be compared with a psychodynamic approach called existential therapy or ET. And all of these are compared in terms of their outcomes of relational aspects and differing treatment durations of both therapies. CBT is the most readily standardized and researched intervention in trauma treatment to date, and has been noticed for its more stringent adherence to operant conditioning principles in treating distorted thought patterns of survivors. Traditionally, cognitive therapies have short-sighted a broad range of common emotional experiences of PTSD survivor to just fear responses, thereby reducing the survivor's experiences as merely an anxiety disorder. Eventually, PTSD was established as a separate diagnostic category to better explain a survivor's unique experiences of intrusive memories or flashbacks that fear or anxiety complex simply cannot explain. In response to the discovery of PTSD survivors' experience of self-blame and guilt, CPT was developed to counter such erroneous emotions. As such, CPT delineates from CBT's overextension of fear conditioning principles to take a more sophisticated consideration in treating survivors' internal processes. CBT clinicians have been purported to make more heavy-handed confrontations to the client's thinking errors, while CPT takes a softer, more indirect approach to addressing such maladaptive cognitions that is more interpersonally inviting and collaborative. There is a strong justification that trauma survivors can be more effectively treated at the direct root of trauma through talking about it, but CBT does not sufficiently consider this. Specifically, Rasika Manson justified that even simply naming comforting objects can activate the prefrontal cortex to quiet down the amygdala. And through CPT's clinician-client discussion around Socratic questionings, this can be achieved, resulting in better affective regulation. Now, looking into the differences between prolonged exposure and CPT are that they are the two most common forms of evidence-based CBT treatments that has indicated highly efficacious outcome in treating PTSD survivors of war and interpersonal trauma. While CBT's purview is limited into addressing the PTSD survivors' specific problem or symptoms at hand, PE and CPT extends its lens into also considering the survivor's ability to adjust to psychosocial functioning in the long run. So in comparison to CBT, PE and CPT share most similar advantages to treatment outcomes. And as I'm going through the slide, I noticed the title of the slide should be PE versus CPT. So my apologies. Now looking more in depth into comparing CPT with a psychodynamics approach. And and specifically that approach is ET. So a bit of backgrounder behind ET is that it is a psychodynamic intervention, which is more of an approach or philosophical way of knowing than a technique. Modern psychodynamic interventions like ET are often integrated with other therapies to enhance treatment of psychological or physical diagnoses. For instance, a couple of researchers found that patients who experienced chronic pain who were treated with existential focused CBT experienced better pain management outcomes than those treated with CBT alone. Currently, there is very little empirical research into ET as a standalone approach to treating PTSD. However, anecdotal research points of its benefits in treating those with complex or chronic trauma. So, for instance, a researcher used an existential approach to counsel individuals traumatized by adverse childhood experiences, or for short, it's ACEs. Which led to enhanced symptom reductions. So overall, existential insights can foster the acceptance of human suffering, inclusive of trauma, that enhances one's resilience to move forward in current and future realities. Both CPT and ET would agree that clients' awareness to flawed cognition pertaining to trauma impacts their emotional capacities, and that some form of emotional exposure has learning potential to reduce the impacts of such thoughts. ET would describe this learning as insights that are altered visions of past thinking that can be drawn from existential discussions about purpose or the meaning behind said trauma, and in doing so, this supposedly reduces the power of the dysfunctional behavior, whatever it may be. The outcomes from existential discussion similarly parallel to that of CPT's Socratic questioning and discussions of stuck points. Both CPT and ET offer strength-based perspectives through looking at the survivor's skills to enhance and their personal self-responsibility taking, which can all enhance the client's existing determination for therapeutic change despite their suffering. So relative to CPT's shorter therapeutic duration, ET's longer paced delivery allots more opportunities for supportive interventions, such as person-centered approach, which naturally unfolds in solidifying therapeutic alliances more so for ET than for CPT. The existential approach behind ET has yet to be consistently operationally defined and thereby difficult to standardize, and as such, do not elucidate empirical methods that can be currently validated that the way that CPT can. Further, opponents of ET have noted that its narrative components alone may not be sufficient to changing the cognition related to trauma memories the way that CPT's more systematic cognitive processing can. Overall, clinical research is still developing to validate therapeutic outcomes of various trauma treatments in current literature. As such, empirically based interventions like CBT or CPT should not overshadow techniques such as psychodynamics, which have not yet developed into empirically validated standards. Now moving on to the last phase of this webinar, which is looking into the recommendations of CPT this current time. So even though Rasek and Monson broke down CPT treatment of PTSD to 12 sessions, other studies found varied durations that required less sessions to still achieve expected treatment benefits. As such, future replication studies can identify any redundancies in the number of sessions or components of CPT that can be removed. Further, real-world implications of shortening sessions may be better suited for clients under certain circumstances, such as having limited insurance coverage. Follow-up studies should clarify recent findings of different markers of CPT delivery affecting varying therapeutic outcomes in reducing post-traumatic symptoms. For instance, a set of researchers found that therapist adherence is associated with higher reduction of depressive symptoms, while therapist competency was associated with greater improvements in post-traumatic symptoms. And recommendation was based only on evaluating CPT as a treatment for group format. Future evaluations should include treatment in other delivery formats, such as individual or hybrid treatment groups. There may be other factors contributing to CPT's efficacy that may be confounding with the efficacy of group CPT that may not necessarily lend similar treatment outcomes for, say, individual therapy. Future research can look at integrating other approaches with CPT, such as we learned, existentially focused CBT can perhaps be forwarded to be added to CPT, which can parallel enhancing treatment outcomes. And that concludes the recommendation section of CPT. And thank you very much for watching this series. I hope you found this very helpful and useful. And if you have any questions about the content shared, please message me, and I'll just leave you with some references that were used.